cause the transition. And so now it's volume targeted pressure support. So it's just like putting somebody on BiPAP on an ET tube and just turning the pressure support up and down every breath in pursuit of a target tidal volume. Okay? So, but as the patient breathes more, the ventilator does less. So you're which is how patients wean, right? You're transferring work of breathing from the ventilator to some extent to the patient, then more to the patient, then a spontaneous breathing trial is little or no support from the ventilator for a period of time, and hey, Phil's ready to be extubated and we pull the tube, right? Do you want to have a patient with one of those disease processes breathing 40 times a minute and the ventilator's not doing any work? Probably not, right? So the benefit of ASV in your situation, one of the benefits works against us. That's why we're calling Plan B what would be the mode we would use. And so we would use that PSIMV plus mode for those types of patients. I guess the operative thing is any patient that has an excessive drive for whatever reason, probably, unless you're going to sedate them, probably should not be used on ASV, because what will happen is that drive will be interpreted by ASV as the patient wants to wean off the ventilator, and the ventilator will wean support, and you'll have a patient intubated on the ventilator, and the patient will be doing all the work. So probably not a good thing. Could you do it? You could, but you're on the wrong side of the efficiency curve. So we're going to use this PSIMV because there we can set a pressure control or pressure support, which will be one and the same level, and no matter what the patient does, the ventilator is still going to deliver that same amount of support. Okay? By the way, if you have a patient that is spontaneously breathing, and so both those patients in those displays up there, those screenshots. By the way these slides are made is this little port on the side there's a thumb USB port underneath that, and all you do is stick a thumb drive in there and bring up on the screen whatever you want, and you press this button here that looks like a printer, and it writes a JPEG of that right to the screen. And so I just say, hey, here's what these guys are probably going to want to talk about. I create the scenarios that go along with what we want to talk about, and so instead of having to fumble with, because you've seen operator error a few times here this morning already, we don't want to get caught up in that, right? So I just create the slides. So it's not a bad idea, and I'll mention it to management, that especially early on, you know, it might not be a bad idea to have a thumb drive handy, and if you see something that you kind of go, I'm not so sure, or, you know, I'd like to talk about that later, pull that rubber cover off, stick the thumb drive in, and hit the print screen button, and maybe do one of the main screen and one each of the 3 monitoring tabs, and then you could email it to me or one of the clinical guys or whatever, and we could talk about it, and we could have a conference call, or we could email back and forth. So, you know, we're now like a virtual employee. I'm on your team, and if you need help, just let me know. You know, and if you have a problem, when you have a problem, you need to let me or somebody know about that so we can find out, is it an educational thing? Is the ventilator not doing what it's supposed to do? Which doesn't happen very often, but occasionally, you know, they're mechanical devices. Sooner or later they break down. But if you press your monitoring tab and you go to tab number 3, yours won't have any values there right now, but the third one down on the left side is P0.1, and that's a work of breathing index. It basically says how hard is the patient pulling, if you will. And normal P01 is 0, and it's always a negative number or a dash. If you're not touching your test lung, then it's just a dash because there is no work of breathing. If the patient's breathing, then, so if I just trigger this gently, you'll see that there's a number that appears on the next breath. So that's minus 1.1. So that patient has minimal work of breathing. 0 to -3 is normal. -3 to say -5 is moderate, and above that is excessive. So this patient's breathing spontaneously, but the rate's okay. They don't look like they're in distress. The rest of the vitals look okay. It's all volume targeted, so that's still a good thing. They're going to be guaranteed that minute volume we've dialed in. So maybe instead of sedating them, I'll just let them go. It's okay. But if the patient's breathing on their own and you're getting numbers like -15, you know, or -6 or -7, you know, the patient's working pretty hard. So you could either sedate them or you would increase the level of support to blunt their drive. So it gives you an objective way of saying, well, I wasn't sure, they looked like they were breathing kind of hard. You know, you have something else that you can refer to if you want to. Okay, just going back. So all of your measured and monitored parameters are under the monitoring key, and there's 3 tabs, so there's 24 measured and monitored parameters underneath there. Okay, so this was just a review of, on the screen there, of, look at that tidal volume, a liter. We had a patient in a hospital in Grand Rapids that was on a Hamilton ventilator, but not on ASV, and she weighed about 50 kilos. She was in her early 60s. She had really bad COPD, and they did a blood gas on her in the middle of the night, and her pH was 6.9 something or other, and her CO2 was just under 200. Her pulse ox and her PO2 were okay. Her blood pressure was crappy, and her heart rate was high, and her peak pressure on the ventilator was really high, and her plateau pressure was really high. You know, she was circling the drain, right? So they said, well, hey, we're not getting anywhere doing this. Let's put her on ASV and see what happens. So we talked about it, and the intensivist said, well, what's going to happen? And I said, well, and I told him, and then we did it, and that's what happened. But so she'd been on a tidal volume of like 410 and a rate of 13 or 14 with the aforementioned bad physiologic parameters. So we put her on ASV. ASV put her on a rate of 5 and 15 mLs per kilo. Holy moly, that's a lot of tidal volume, right? Aren't you going to blow a lung? Well, 20 minutes later, her pH was 7.32, give or take, and her CO2 was in the mid-60s where she lived. Pulse ox and PO2 were still good. Peak pressure was lower on more than twice as much volume. Plateau pressure was lower on more than twice as much volume. Blood pressure was up, heart rate was down. Looks good to me, right? Well, how is that possible? Well, she had so much dynamic hyperinflation, it would be like me saying to you, okay, take 3/4 of a deep breath. Now you can't exhale below that, but now breathe on top of that. Her lungs are already full of air, and they're trying to, she's trying to ventilate on top of that. So the only thing we did is we disconnected her from the ventilator for about 30 seconds. I mean, her gases weren't going to get any worse, right? Gave her a whole lot of time to exhale. And then we connected her up and put her on ASV, and she did, yeah.
So she was stacking respirations, basically?
Absolutely. You know, it's the old 500 in, 450 out. Sooner or later, But it's not uncommon that clinicians, therapists, nurses, physicians, interpret or remember, maybe selectively, that lung protective ventilation strategy is 6 to 8 mLs per kilo. Well, that doesn't work especially in really obstructed patients, because they need a lot of time to exhale. So if you're using a low tidal volume and you have to have a minute volume, there's only 3 factors in there. It's rate, tidal volume, and minute volume. So if you move one and another one's constant, the other one has to change too. So if you turn the rate down, you got to turn the tidal volume up. And I would guess, the smallest person in the room is you, and if we hooked you up to the ventilator and I said, just give kind of a normal sigh, I bet you that would be 1,500 cc's easy. Our normal inspiratory capacity is 3,500 or 4,000 milliliters. Have you ever given I would defy any of you to give yourself a pneumothorax right now without taking a deep breath and throwing yourself on the back of the chair. It's just not going to happen. Now, obviously sick people have diseases and blebs and other things, but I would purport that, when the patient's not done exhaling and the ventilator's giving him another breath, that's a bad thing. All of those things anecdotally get put into a bucket called ventilator-induced lung injury. So it's something that we, certainly not intentionally, some harm or whatever that we've caused to the patient by the ventilator not being set properly. And unfortunately, not because people aren't good and caring and wanting to do the best thing, or that they're not using good equipment, It's just that we can't be at the bedside constantly, and that's why technologies like ASV are evolving, and in the future, probably long after certainly I'm dead, most people will be ventilated on closed loop type technologies. And the next thing will be you put a Bluetooth chip in there, and it talks to the communication system on the ambulance, and it broadcasts on a screen to your medical command. And so if you have a problem, you go, hey Daniel, I'm having a problem, and he goes, oh, let me take control of the ventilator, and he tweaks the controls, and and that's going to be the next thing probably. So there's already talk about putting Bluetooth technology into the ventilators. So that other slide was, the basic settings are not, huh?
You won't need the paramedic anymore.
Oh, so you know what, we hear that kind of stuff all the time. So here's my analogy to that. If I said, because in repayment for your kindness this morning and your patience and not falling asleep during this, we're all going to go to the Bahamas next week, first class. Everybody gets a drink. As soon as you get on the plane, we'll give you a drink with a little umbrella in it. We'll all get on, get comfy. We got nice big seats. And the pilots are going to come on. They're going to set the autopilot. Then the pilots will get off the plane. We'll close the door and be on our way. I would just warn you that if you're not planning on getting off the plane before that happens, don't stand in the doorway because I'm going to run you down getting off the plane, right? So would you set your car on cruise control and hop in the back seat? It's monitor and observe. So yes, it does some things that you don't have the ability to today. Yes, it's got some intelligence. It's still a machine. It still needs us to go. But especially in an intensive care unit and actually in the environment you're in, it's a complex environment. You got a lot of stuff going on. A monkey can turn the dial. It's knowing what to turn and when to turn it. That's the important part. You've got IVs, you've got communications, you've got God knows what other things you have to deal with on the aircraft or in the ambulance. And so really all you're relegating ASV to do is to turn a few of the more fundamental dials, primarily rate and tidal volume. You're still managing the patient. So you don't have to manage the ventilator. I think it would be best served if you spent your time managing the patient. And that's why, we can't, when I started, this was an expansion territory, when I started 8 years ago, for the first year, if you looked at my phone records, they were all outgoing. If you looked at it now, and there were 3 of me, there's calls I can't get to. So, it's just. So let's go to that PSIMV mode for a second. So hit the mode button and hit the PSIMV and confirm again, if you would, please. And then hit the controls tab. So it should say PSIMV up here in the upper right-hand corner, right? And interestingly enough, it brought all the controls over with it from the other mode. So it set them all automatically for you. There's a little checkbox called IntelliSync, and we're going to, by default, that's going to be on for you. So remember when we first turned the ventilator on, you're probably not going to go from one mode to the other. You'll pick it when you start. Remember there were those 3 keys at the beginning, and the PSIMV was the middle one. It's better to select the modes from here than up here because I've already pre-programmed in all your alarms and things related to your protocol. Okay. Okay. So the PSIMV is selected because that allows the ventilator to use the same pressure control, meaning if the patient isn't doing anything, how much pressure is it going to use for both the mandatory and the spontaneous breath. So the patient's, in this case, always going to get 15 centimeters of pressure, and so the P plus the PEEP is going to give you, 19, 20, 21. So if the pressure is constant, what's the variable become? The tidal volume. So now you have to manage the tidal volume. So as comfortable as we were with having ASV do it, we're back to, okay, we have to manage it. So if you turn the pressure control up, you'll get more volume. If you turn it down, you'll get less volume. But you're also adjusting the rate and the I time and all that, just the same as you do today. Again, the reason we're using this is because if the patient's pulling real hard, and that was those patient groups that we wanted to set up on this mode, that the patient wouldn't wean off the support from the ventilator. But you're going to have to manage the minute volume and the tidal volume. Okie doke. And then you have the same controls, the P-ramp and the ETS as well. One other thing that's a little more maybe complicated in thinking is the way that PSIMV plus works is that if the patient doesn't breathe above that rate, that rate and that inspiratory time will be implemented. If the patient breathes above that rate, so 16 or more, it's as though the rate and the inspiratory time parameters go away. So if you have a patient that seems to be doing generally okay, and you're not going to sedate them into next Thursday, but they seem to be struggling and fighting against the ventilator, try turning the rate down below what their spontaneous rate is, because then the breaths will switch from being time cycled to being flow cycled. The patient can determine their own I time, their own I ratio, and they may become more comfortable and more synchronous with the ventilator. Just, don't walk away real far because you're going to have to, if they crap out on you, you're going to have to turn the rate back up. Okay? And then the last mode that we're going to use is the non-invasive NIV-ST. And 99% of the time that's going to work okay for you. The big difference between NIV-ST and what you're using today is primarily in the controls. So on many home care and some institutional ventilators and BiPAP devices, the control variable is not the inspiratory pressure, it's the IPAP value, which is the peak pressure. So you'll notice here the 15 and the 5 is producing 1920. So the P-insp value and the PEEP value produce the peak pressure. So the easiest way to ask when you get to a referring facility is, what's the peak pressure? It's 20. What's the PEEP? 5. So subtract the PEEP from the inspiratory pressure and then set the P-insp to that value. So if you put 20 over 5 in here, your peak pressure is going to go up to 25. Okay. But that's the only difference. Another thing, if you go to the Systems tab and you look in the bottom left-hand corner, there's a thing that we've activated, a switch that we've turned on for you. It says O2 consumption. So if you're using, which you will 99.9% of the times, the high-pressure hose connected to a tank, and after 2.5 minutes of running the ventilator, a number, and you're not on room air, that will produce a number based on the I time and the FiO2 and the rate and all that kind of stuff, the minute volume. And right, mine's saying 0 now because we're on FiO on room air. But it will produce a 3, 4, 5, whatever number, 3.5 number. You know that on your rigs, whether it's the aircraft or the ambulance, you have a tank, and the tank has a pressure gauge, and you multiply the pressure in the tank times some factor, the tank factor, and the byproduct of those multiplying, or the product of those two things, is the amount of liters of gas that are left in the tank. And if you take that liters available in the tank and you divide this number into it, it'll tell you how long the tank's going to last at those settings. Okay. A couple of other little things here, just as we close up. The yellow port on the side of the ventilator is for a nebulizer. The best place to put that would be between the circuit and the flow sensor. Depending upon which nebulizer you use, you might need a couple of adapters, so that would be something to look at. In a pinch, you could put it in front of the flow sensor, but if you put it in front of the flow sensor, you absolutely must power it off the ventilator and must not power it off of something in the rig or the aircraft, especially if you're in ASV, because remember that flow sensor is measuring volume going in both directions, and if you're running it on a continuous flow, during exhalation and after the patient's done exhaling, the ventilator is going, there's not enough pressure from that nebulizer to push it into the patient. So which way is the flow going to go? It's going to go past the flow sensor towards the circuit, and the ventilator is going to say, hey, the patient's still exhaling, I'll wait to give him the next breath. We had somebody put a patient on a, 1 breath a minute kind of thing as a byproduct of that, so you don't want to do that. So, but the best place is between the flow sensor. The best place would be there, yeah. Back one intersection, right there, yeah. And in 100,000 words or less, that's all I have to say about that.
That was the fastest 2-hour training I think I've had.
Well, thank you. You're very kind. Let me give you, if I can find them, some business cards. If I don't, my contact information is on the presentation for you.
And that's 3 o'clock in the morning, you're going to answer that, right?
Yes. You know what? Everybody, that's a very common thing, and in 8 years, you know how many times I've had calls in the middle of the night? I think twice. Also, sorry, good. That's an excellent segue. Notice on top of the ventilator, there's a little blue sticker. Yes, thank you very much. We know you're there. On top of the ventilator, there's a blue sticker with an 800 number. There is always a person with a clinical background on call 24/7, 365, and in the leap year as well, available for you. So if it's manned live Monday through Friday, Pacific time, 8 to 5. After hours and on the weekends and on holidays, it would be picked up by an answering service. Just give them your name and a phone number where they can reach you, and usually within 10, 15 minutes, half hour at the most, somebody will call you back. Years ago, they had technical people answering the calls, and guess what? At 3 o'clock in the morning, you're not getting a call saying, hey, my flux capacitor's not working. It's usually, hey, the patient's not doing well, and I'm not sure what to do, or the ventilator made a crazy alarm, and I'm not sure what to do. So, we are here for you. You know, we can't be your education department. I can't, unfortunately, ride along with you, which I would love to do on every transport. But if you have a problem, when you have a problem, please let me or us know. And eventually, it'll get to me, no matter who you call, and because we want to fix it for you. And if it's something that's educational, we can do face-to-face like this, one-on-one, or in groups. We can do webinars. We can do, I've had people say, hey, I'm working a weird shift, but could we do Saturday afternoon at 3 o'clock? And I'll set up, most people have Skype on their home computer, and if you don't have a sound card and speakers, all you need is access to a phone number. I'll give you an 800 number, and then you can look at my computer screen, and we can do whatever we need to do to get you what you need. So the only onus is on you, is that if you have a question or a problem, please call or let us know so we can help you out.
So one, not really hypothetical, happened a year or so ago, we took a patient, complicated pulmonary history. Pulmonologist wanted him to set a very specific, I mean, everything
Settings.
was very specific for that patient. We couldn't accomplish that with our transport ventilator. They actually sent their respiratory therapist with them. Will the ASV mode kind of bridge that gap between facilities, or would that still be our go-to, just to rely on whatever that pulmonologist has?
Oh, and that's a really yes, no, and maybe question answer, in my opinion. So
Dan, my guess is if we're picking, say you're picking somebody up from Brian and you're taking them to Fort Wayne, and the pulmonologist that Brian said, these are the settings I want, this machine will accomplish any setting that we want. If there's nobody, then my guess is we'll go to the ASV mode. Yeah, if Katragana is calling us from here saying, hey, these are those settings that I want for this patient in that uncontrolled environment, then we're going to set it up based on that.
Yeah.
Whether it's a controlled setting, whether it's a pressure setting, whatever, we'll set it up like that. But otherwise, we'll do ASV.
And the side note, I agree completely with that. The side note is that don't be alarmed. It probably won't happen all the time. Hopefully, it will never happen, but most likely it will. You'll go to a referral facility and you'll say, what's their exhale minute volume, what's their PEEP and their FiO2, and you dial that in, the stuff you need to dial into and you get very different settings. That's because perhaps, arguably, the patient was not on the best possible settings to begin with, i.e. the woman I was telling you about, that in Grand Rapids at a hospital that shall be nameless. And that wasn't a, that's a fun conversation to have in a room full of physicians, because the way I phrase it is I tell them what the settings were, and I tell them what the blood gases were, and then I tell them what ASV did, and I say, by a show of hands, who would put a patient on those settings? And nobody raises their hand. And then I say, well, before you eviscerate me, let me tell you what the scenario looked like 15, 20 minutes later, and then I tell them the same story I told you. Then I say, by a show of hands, does anybody object with the results? Once again, a conspicuous absence of hand raising. Thank you so very much for your kindness and your attention, and look forward to working with you going forward.